Right, welcome back, everybody. This is the second of our podcasts about HRT. In the first, episode 52, if you'd like to flick back and give it a quick listen, we explored the impact of menopause in society, the increased awareness in the public, and the importance of starting those conversations with patients. Menopause, of course, affects half of us at some point. It's in the news, it's on social media, it's on people's minds, and so it's important that we get it right, understand the patient's journeys, and give the best treatment possible. There are, of course, loads of treatments and approaches, but it can be sometimes a really complex world. So to help unravel and wrap all things menopause, it gives me great delight to welcome Dr. Sam Dobson to the podcast. Sam's a consultant gynaecologist, a fertility subspecialist, a menopause specialist, and a fellow Nottingham alumni. Welcome, Sam.
Hi, Jay. Thanks for having me.
Yeah, it's great for you to join us. So I suppose to start off with this increased awareness of HRT, we're often actually directly asked for a lot of medications, specific treatments. We asked about bioidentical hormones, which I think we're going to talk about at another podcast. But the other one is testosterone, which I didn't really associate with HRT. So, Sam, can you try and demystify this for us? Let's get back to basics. So, what is testosterone in this context? Why are we thinking testosterone?
So testosterone is a hormone that's found in men and women. It's for the female. It's made by the ovaries, along with estrogen and progesterone in the reproductive life. As the lady goes through the menopause and the ovarian reserve diminishes, and there are no eggs left, the testosterone production ceases as well. However, women do make testosterone in the adrenal glands as well. So in the menopause, there is a small amount of weaker testosterone called DHEA produced by the adrenals. So this hormone, though, specifically is really responsible for libido and sex drive. So in women, it's in the menopause, it's often coined as hypoactive sexual desire disorder, which just means low libido.
Sure.
So it's sort of, people think it's responsible for that. Yeah.
Sure. And so it sounds like the testosterone is largely linked to that's linked to sex, linked to libido and all that sort of thing. So what sort of symptoms might they present with? What might they say to us?
So along with the routine sort of menopause symptoms like hot flushes, insomnia, anxiety, they may describe, or you may have to prompt them, but they may describe having a low libido, essentially, no sex drive, no interest in their partner anymore. That's it, really.
Yeah, sure. Okay. So it's more sort of single thought in that respect. But I think that one of the things that we're starting to understand a lot more is that, sex is a multifactorial thing. It's not just about libido. And it sounds like there'll be other things that are related to menopause that can impact on that. There's estrogen and vaginal dryness. How do you go about approaching this problem in a consultation?
Absolutely. So I'd take a more sort of global approach to libido, and I'd think about, simple things like, do they feel sexy? So having hot flushes, not sleeping, that can't help. So if you can improve that with estrogen, then they may then feel sexy and have a libido. Or they may struggle with vaginal soreness, dryness. It may really hurt to have sex. They may bleed when they have sex. Or they may even have other conditions like lichen sclerosis, which makes sex painful. So is that a reason rather than just a low testosterone? And do they fancy their partner? Equally. So don't rule out other reasons, and I would definitely take a biopsychosocial approach to libido. So yeah.
Well, a wise person told me that you have sex with your head rather than with your genitals. So I think addressing all of those other things and making sure that people are in the mood to have sex and kind of exploring that in the biopsychosocial way is quite important to get down to exactly the crux of the problem.
Yeah, definitely. I think, you want to feel sexy and want to have sex. Genitals help, though.
Yeah, well, yeah, absolutely. They're quite important for that. It is a tricky thing, and as we're talking about it, I think some of the natural Britishness comes through. It's difficult to talk about sex, and I think patients are getting more up upfront about it, especially with things that are going on in the social media and the media and asking people about it. But it can be quite hard to bring that up in a consultation. I think about a normal general practice, sexual history. We're thinking about STIs, we're thinking about number of sexual partners. But how do you go about approaching that, actually the physicality of having sex? I find myself tripping over this, even as I ask you.
Yeah.
How do you bring that up?
No, absolutely.
What tips can you give us?
I think it is British, isn't it? It's difficult to look you in the eyes and talk about this.
Yeah.
I think not many patients will bring it up. Certainly not initially.
Yeah.
I think the key things are you have to build a good rapport with the patient, and they obviously have to trust you. And you normally start with just a general history taking and symptoms, general menopause symptoms, and then if they haven't mentioned it, then at the end I would maybe prompt them and say, I'd start maybe with vaginal symptoms, menopause symptoms. Are you struggling with any dryness, soreness? And that might open it up. And then you might say, are you sexually active? They may say no. But actually then to follow that up with, do you want to be sexually active? Is that your choice? Or are you sore? Does it hurt? Do you not have a libido? These sort of questions. And most women would be more than happy to talk about it. And I think are actually probably quite grateful that someone's brought it up. Because, whilst some women, I'm sure, just don't want to have sex, and that's absolutely, that's fine. It does have an impact on relationships for people that do.
Of course, yeah.
Yeah.
Completely understand that. I think it's all part of formulating that plan and personalizing the care, personalizing HRT, personalizing menopause treatment to the patient. I think there's a really nice way of sort of bringing that up and asking people what their aspirations are. You've also mentioned some about the vaginal symptoms, and I understand that's more to do with estrogen. I suppose if we are starting at a place, should we be starting with estrogen?
Yeah, so I think it's sensible to start with estrogen. I think estrogen HRT is licensed. We know a bit more about its safety profile. It's easier to counsel them on the risks. And if it's if you improve hot flushes, sleep, anxiety, can improve vaginal symptoms, they may be absolutely fine, have a libido, and that's it. They don't need testosterone. So yes, I would start looking at estrogen to begin with. Then if you've sort of treated the systemic menopause symptoms and vaginal symptoms, and if they're still complaining of lack of libido, I would then consider testosterone at that point. Yeah.
Can estrogen itself as HRT help with libido?
Yeah, absolutely. Yeah, for those reasons, if you're not sweaty, sleeping better, feel your skin's nicer, are less anxious, more comfortable, then I think that it itself can be enough. Yeah.
I mean, a question that sometimes comes up in conversation with other GPs is if a patient is receiving patch HRT or pill HRT, but are still having those sort of urogenital atrophy or vaginal symptoms, is there anything else that we can do to treat that and make it a bit more comfortable?
Yeah, so it's important to remember that about a quarter of women on systemic HRT with the urogenital symptoms, so dryness, soreness, will not have an improvement in their vaginal symptoms with systemic HRT. So they do need an additional vaginal sort of HRT, such as Vagifem or estrogen cream. Yeah, and that's safe to add in to any systemic regime because so little of it's absorbed, it doesn't really impact the endometrium and the risk.
Yeah, and you've mentioned before about kind of getting started with that cream and kind of managing their expectations. I think that'd be really helpful for our listeners.
Yep. So the key thing for vaginal estrogen is to start sort of intensively. So to use it every day for 2 weeks. So sort of re-estrogenize the cells. The vaginal cells will become stretchier, thicker. They'll produce more sort of fluids and mucus. So lubricant. And then once you've done that initial 2 week sort of intensive treatment, drop it down to maintenance once or twice a week or twice a week, which you could continue for 6 months to a year. Yeah, and if it's of a benefit, then carry it on longer. Yeah.
Excellent, brilliant. So we've sort of addressed the general HRT sort of questions there. We've had a talk to them about sort of the psychology and the light behind this as well. So we're on to testosterone, which is obviously what today's mostly about, our conversation. How do we get started?
So in my consultations, I would start by exploring the symptoms and, conventional HRT. But if we've got to a point where they've tried systemic HRT and they're still struggling with libido, then I would say, well, let's consider testosterone. First of all, I would discuss the risks. So I think the key things to counsel the patient about is it is unlicensed. Certainly in the UK, there's not a huge amount of long-term safety data, and there can be side effects which can be sort of reversible and irreversible. So side effect wise, I would explain, if they got any, then to stop treatment. So sort of mild common ones are sort of black hair growth, acne, weight gain perhaps, and then you've got the sort of more serious longer term irreversible side effects such as alopecia, deepening of the voice, clitoral enlargement. Now these risks are low, the side effects are uncommon, and they're especially uncommon if you can maintain the testosterone in the female range. So I can talk about that as well. So once you've done that, and if you've not put them off, then you could, then I would take a baseline testosterone level. So just a total testosterone. That's essentially to make sure that their testosterone level isn't completely normal, because if it is that really why they've got no libido? And if you give them more testosterone, you're then going to push them into the male range with the side effects. So just check it sort of is low. Provided testosterone is low, commence a treatment of some form. Sure. Yeah.
So do you think that this pre-treatment level is quite essential before treating people?
Some clinicians don't do it. I think that the BMS guidance is to do it.
Okay, so
and I would do
BMS guidance on this too.
Yeah.
Excellent. Is that guidance available for us as GPs to?
Yeah, the BMS website's got a clinician's toolkit with some really good PDFs that you can download and give to patients and read.
Brilliant. That's really great to hear. I mean, and we're about to talk about the actual treatments and about what one might prescribe. Is this something that we're doing in primary care, or is this still kind of in the realms of the menopause specialist?
At the moment, a lot of it's coming through to menopause clinic, but I think there is a move towards, as with conventional HRT, GPs becoming more confident. In my region, we have sort of been involved in the production of a guideline for GPs wanting to start testosterone. So I think there will be certainly a shared care pathway. But yeah, I think with time,
Yeah. Sure. And I think it always comes with a little bit of anxiety when we are doing things in unlicensed with medications. But evidently, the more we do it, the more data we have, and the more patients that we can help. That could be really useful. So moving on to the actual prescription, how are we actually giving a patient testosterone? How are they receiving that?
So there are different formulations, different products. It all really depends on what you can get hold of. You've got things like Testogel, which is in a sachet. The sachets are sort of 40 or 50 milligram sachets. You want to aim about 5 milligrams a day. So you ask them to take 1/8 of a sachet each day. So most of the preparations are for men, which is why you have to do these sort of taking 1/10 and 1/8 of a sachet. It's difficult. It's not straightforward, but you could give them a syringe to help them if they draw sort of 1/8 of the sachet up into a 1 ml syringe or something. And then you just apply it to the skin, clean, dry skin.
Just sort of rub it in.
Moving sort of, changing the area that you rub it in every day to avoid sort of hair growth in that area. They should keep it uncovered for sort of 20 minutes, half an hour, let it dry in, then they can get dressed once it's dry and avoid contact with sort of other members of the family for that time, and then they can swim and shower and a couple of hours later. So that's that option. Then you've got things like Testim, which is a 1% gel, so it's a 1/10 of a tube a day. You've got Tostran, which is a 2% which is in a canister. It's a 2% solution, so it's 1 pump on alternate days because that's 10 milligrams. So you sort of do that every other day. In Australia, you've got Androfem cream, which is a 1% cream. You apply 0.5 ml.
That's actually licensed, I think.
That's licensed in Australia. I think you can get it in the UK, but I think it's possibly on private prescription. And then you've got testosterone implants, which aren't on the NHS either, but you put them under the skin and commonly the lower abdomen or buttock, and it lasts about 6 months. That's a 100 milligram pellet. So that's the options. That's how you apply it. Be very careful. Don't give it to anyone with hormone-sensitive breast cancers, or avoid pregnant women, obviously, liver disease, and if you've got athletes or anybody competitive, just warn them that it might show up on a drugs test and things, and if they do want it, you just have to be very careful to keep it in the female range.
Okay. So should we be monitoring patients after we're giving that? How sort of frequently should we be doing that?
So the guidance is generally at 6 weeks, but realistically 2 months, 3 months, just so once they're sort of on the regular treatment, just check their levels again. And all you're looking to see is that the testosterone levels are A, higher than they were, and B, are still in the range of it for a female. And that's how you avoid side effects. If they do get side effects, they should obviously stop the treatment.
It's really good to know. So obviously we've got lots of these treatments here. I think one of the main things that we do in general practice is often explain to people about the side effects, which we've mentioned. Are there any real contraindications? You mentioned breast cancer. Any other contraindications or any serious things that a patient might be worried about? Evidently, we're getting much better at that with normal HRT or estrogen-based HRT.
Yeah, I think we do lack that data now, really, of what there's no evidence of. There's no evidence of cardiovascular benefit, and there's no evidence of cardiovascular risk either. So we don't know. I think that data will come out. But I think the key thing is, because we don't know, if they are not having a benefit from the treatment, don't use the treatment. So if at 6 months their libido is still rubbish, just stop the treatment. I think. And good counselling as well.
Yeah, that's very important. I think finally, the other word, again, we're asked often about these medications. The word DHEA comes up in terms of medication. I think you mentioned at the very beginning of the talk here about the adrenal glands, but would a patient be taking DHEA?
They sometimes are. They may not tell you.
Okay.
They may get it elsewhere. It's in a woman with normal adrenal function. There's not really any evidence it will help her libido. Having said that, some women would want to try it, and fair enough. But there isn't really any evidence for DHEA. It was used in fertility a few years ago, but then it was proven not to make any difference either.
Sure. So, yeah. And I think that's particularly important, and we're going to explore that in quite a lot more detail in our next talk about this kind of personalised care plans for patients for HRT and menopause, and about what they might hear elsewhere, about what they might already be taking, about their kind of ideas and concerns and expectations and all that good stuff as well. So I think I'm really looking forward to exploring that a little bit further with you. I suppose now, as we sort of approach the end, if you were to give advice to GPs and people working in primary care about this particular area, libido, sex, testosterone, we've covered an awful lot today. What would it be? Is there any kind of final words you can leave us with?
If a patient comes specifically, with complaining that they're struggling with libido, I think take a global approach to it, really, and assess sort of all the different factors that, down to, the really basic things like foreplay, and sort of ascertain how you might be able to help. And I think, don't be afraid to start with vaginal estrogen. It is essentially very safe. And then, consider systemic estrogen, and other factors. And then, if that hasn't worked, then consider testosterone. If you're not comfortable, right to the hospital, right to the menopause clinic for advice, or refer them in.
Excellent. Well, thank you so much. I've certainly learned loads today, and I think that our listeners are going to find it really useful finding out more about that, because we're asked about lots of things, and in this very rapidly moving world, it's really good to know about about this medication. So I really look forward to our next podcast and lots more. I think there's lots of things that we could cover. So thank you very much for your time this evening.
Thank you for having me.
Absolutely. And we'll catch up again really soon.